morning, everyone. And for the ones who, my name is Vincent Claus, and I'm a part of the board at MPE. The next session will bring us to MRD, or minimal residual disease. And Dr. Leal da Costa already touched the point, so you already had a little glimpse of the subject. MRD is more and more important in multiple myeloma. It's precise way to measure the evolution of the disease, the treatment response, and to predict the outcome. There are different technologies, and I guess that after the session, this will have no secret for you, neither for me. And we are speaking about flow cytometry, we're speaking about molecular biology, and I have to read that and mass spectrometry. So this is improving the detection of the disease, of course, like I said. We use that in clinical trials. Personally, I'm still followed as well on MRD with a clinical trial. But we're seeing that more and more becoming regular in the clinical practice. And we hope that this will help the future regularity for the decisions across Europe. This session will give you a glimpse on the evolution of all these technologies around MRD. And I'm really pleased to welcome Dr. Noemi Puig, who is consultant hematologist at the University Hospital of Salamanca in Spain. She is leading the experts in MRD assessment, and her work contributes in advancing MRD methodologies in multiple myeloma. So please join me in welcoming Professor Puig, Dr. Puig. Thank you very much. The floor is yours.
Okay, so good morning, everyone. Thank you very much for the invitation. It's truly an honor for me to be here. It's a pleasure. You are truly the heroes of this story. And so I'm gonna talk to you a little bit about minimal residual disease in the next 45 minutes. And so the first question here could be why MRD to assess treatment response in patients with myeloma. And so it's true that you all know in the clinic, we as a physicians, we use the response criteria defined by the International Myeloma Working Group, the standard response criteria, complete response, partial response, etc. And so you have an example in the slide, but there are many other examples showing that these standard response criteria have had prognostic value in terms of progression-free survival, in terms of overall survival. So the best response, the better the outcome of the patient. But today you can see also in the slide that so after years of investigating this, of investigating minimal residual disease, we know that actually only those patients that reach MRD negativity, in this case only in the marrow, that are represented in the blue curve in the slide, are those patients that truly benefit from a better outcome in terms of progression-free survival and overall survival. Or in other words, this new MRD negative category has surpassed the previous standard response categories of the International Myeloma Working Group. So the next question would be, with technique can we assess MRD in patients with myeloma? So it has already been commented, so we can use next generation flow in the bone marrow of patients with myeloma. So next generation flow basically identifies the tumor plasma cell based on aberrancies in the surface of the clonal plasma cells and based on clonality as well. We use two tubes, and we are currently using a new sample operating protocol, not new anymore, called next generation flow. But basically, we are able to identify with this methodology, with next generation flow, with flow cytometry, clonal plasma cells in the marrow of patients with myeloma based on aberrancies in the surface of the cells and based on the restriction of the light chain, which is a marker of clonality, basically. So this is what we use to assess MRD in the bone marrow using next-generation flow. We can also assess MRD using next-generation sequencing. It's a molecular biology-based methodology, and we need a baseline sample to identify the fingerprint of the clonal plasma cell, the IGH rearrangement, which is specific of each patient with myeloma, of each tumor cell. And once we identify this fingerprint, this is what we follow and try to identify in the subsequent bone marrow samples in which we want to assess the presence of MRD. So these two methodologies have been accepted by the International Myeloma Working Group to assess MRD in the marrow of patients with myeloma. They have different features, but I would like to highlight a couple of them. So the first one is that, as we have already commented, for next-generation sequencing, so we need a baseline sample to identify the fingerprint of the clonal plasma cells. Otherwise, we cannot perform the technique. We need that reference that we are gonna follow in the subsequent bone marrow samples to identify the presence of residual disease. Next-generation flow, if you have it, is useful, no doubt about it, but it's not mandatory to have a baseline sample to assess MRD in the patient in subsequent samples. And the second thing that I would like to comment with you is the fact that to assess bone marrow samples using next-generation flow, we need the sample to be fresh. So we cannot keep the sample in the fridge for a week and then to analyze the sample, because we are analyzing living cells. And these cells in the fridge, they die, and then, so this sample that we are analyzing is not good enough, it's not representative of the bone marrow of the patient, and it's not useful to assess MRD. So on the contrary, with next-generation sequencing, we can extract the DNA of the sample, keep it in the fridge, keep it frozen, and then we can analyze MRD afterwards with no problem. So those characteristics, I think, are important, and that's why I wanted to highlight them with you. So basically, so we have commented next-generation flow, next-generation sequencing. Both of them are accepted by the International Myeloma Working Group to assess treatment response in patients with myeloma. So which one should we use? So basically, the response is in this slide. So these two methodologies assess different things. So one, next-generation flow, assesses the presence of clonal plasma cells in the marrow. The other one, next-generation sequencing, you follow the fingerprint, the IGH rearrangement of the clonal plasma cell. We are not following exactly the same thing. So the results are not fully superimposable. They are different. We are looking for different things. But the clinical translation, the clinical implications of the results, as you can see in the slide, are fully comparable. We have seen this in this study, we have seen in other studies, and so the clinical value of the assessment of MRD in the bone marrow of patients with myeloma is completely superimposable now, yes, using next-generation flow or using next-generation sequencing. So in other words, you can use the methodology that you have available in your laboratory, in your hospital, closer to your home, using next-generation flow, next-generation sequencing, following the recommendations of the International Myeloma Working Group. You are going to get similar results in terms of the prognostic value that we get from the results, okay? So to whom we should apply MRD, because we have seen that this is useful. So basically, today, so you probably seen the results of this meta-analysis published by Munshi a few years ago. And this is a summary of what I am going to say in the next few minutes. So achieving MRD negativity has shown to be probably the strongest prognostic factor in patients with myeloma, transplant eligible, non-transplant eligible at diagnosis and in the status of relapse and refractory disease. So basically, the assessment of MRD is useful in every patient with myeloma. So we saw that in the meta-analysis that I've just shown you. The meta-analysis was published a few years ago, but we are seeing that now with the current treatment approaches that we are applying in patients with myeloma. So you have the results of the Perseus trial in the slide. So those patients reaching MRD negativity have a significantly better outcome as compared to those that do not reach that status. So here in the IMROTH trial for non-transplant eligible patients treated with a quadruplet schema, so very, the very effective treatment, the one that we are applying to our patients as of today. And here again, so the differential prognosis of those patients reaching MRD negativity, but also in patients treated with the most innovative immunotherapies that we are using right now. So T-cell engagers, bispecifics, and CAR T-cell therapies. So we have some studies already showing that, again, reaching MRD negativity is a very strong prognostic value in these patients. So, so basically, to whom I would say that to everybody, assessing MRD is going to be clinically, is going to be prognostically useful, and if reaching MRD negativity, so the prognosis of the patient, so the outcome of those that reach MRD negativity after the treatment is going to be much better as compared to those that do not reach that status. So we are talking about the marrow, but if you think about it, when we assess MRD in the marrow of patients with myeloma, we only assess a few milliliters of the blood of the patient. But the rest of the marrow and the rest of the potential extramedullary disease of the patient, we are not assessing it with just a few milliliters of blood that we obtain from a single site. So this was acknowledged by the International Myeloma Working Group, and you can see in the slide that also recognized the need of assessing so the presence of extramedullary disease using imaging methodologies. So in the last publication, so the assessment of extramedullary disease at diagnosis and then the follow-up of imaging-based MRD status was recommended to be done using PET-CT. I'm sure you've heard about of that imaging test to assess disease response in myeloma. And I'm not going to go into the details of this because otherwise the presentation will be too long. But basically, so in the next few months, we are going to have a new iteration of this response criteria of the International Myeloma Working Group. Again, PET-CT is maintained, but I think it's important, to highlight the fact that so also the assessment of MRD outside of the bone marrow with imaging methodologies is going to be possible to be done using MRI, so whole body diffusion MRI. So there are quite a bit of data in this regard, comparable results, if not better, as compared to the results of the PET-CT. So in the next few years, we will hear a lot about the results of the assessment of MRD outside of the bone marrow using MRI-based methodologies. So in any case, so the results that we have and the results that will come in the next few years probably, I think we have to keep in mind that that the achievement of MRD negativity in the marrow and outside the marrow using an imaging methodology, so defines the group of patients, defines the best situation for patients with myeloma. It's highlighted with the red arrow, and logically those patients that achieve that status, so no disease in the marrow using next generation sequencing, next generation flow, and no disease outside the marrow using an imaging methodology, PET-CT or whole body MRI in the next few months, are those that actually, as you can see in the slide, in this study and others, display the best outcome. So when should we assess MRD? So according to the recommendations of the International Myeloma Working Group, we should assess MRD when we suspect that the patient is in complete response. So when the immune fixation in serum has become negative. So at that time point, so to confirm complete remission, but I would say that mostly to assess MRD, so it's recommended to perform a bone marrow aspiration and to assess MRD because we have known, the impact, the prognostic impact of assessing it and specifically of reaching MRD negativity. So reaching MRD negativity at a single point is highly prognostic, probably the strongest prognostic factor in myeloma, but even better is not only reaching MRD negativity at a single time point, but maintaining this status of MRD negativity 1 year apart from the first one. And even better to maintaining 2 years apart from the first determination. So this has been shown in this study and many other studies. It's a logical thing, but we have seen this, recently, and so I would say that it's an important thing, to keep in mind and to consider. So when we are, seeing you in the clinic and we are taking clinical decisions, especially in terms of maintenance therapy, I would say. So it's important to reach MRD negativity at a single point. It's more important to maintain this status of MRD negativity. And so MRD has been tested in many clinical trials, so you all know this. And so as a consequence of this and other trials that have been performed in real life as well, of course, and I would say that after all the data that have been generated for the last years in patients included in trials showing this very high benefit of reaching MRD negativity, 2 publications were published. So the first one was the one that you have in the slide right now, the evidence meta-analysis from the group of Ola Landgren. And then the publication of the I2 team, so lots of companies, universities, lots of people working in this initiative. And basically, so the results of these 2 efforts, I would say, so have prompted, I'm sure you all know, so the approval by the FDA of the use of MRD negative CR as an early endpoint for conditional accelerated drug approval in patients with myeloma. So I think this is a very important step forward in the development of treatments, of treatment combinations, treatment strategies in patients with this disease. So basically, just for you to know the amount of data that have been analyzed these are the results of the I2 team effort. You can see in the slide that more than 10,000 patients. And basically, so the results have confirmed what we already knew in terms of progression-free survival, in terms of overall survival, and also in terms of, at the trial level, a little bit less evidence, but in my opinion, good enough to go ahead with this, which I find a step forward to solve the problem that you have in the slide right now. So now we are very happy with the results of the trials that we are applying in patients with myeloma. But so the price of success is that if we have to design a clinical trial as of today to show benefit in the experimental arm, if our control arm is the Perseus trial, we are going to need a very high number of patients and a very long time for the trial to mature and to be able to apply the experimental, potentially better arm in patients with myeloma. So, this is the strategy, not perfect. So there are no perfect things in life. So it's not perfect. It has its caveats, of course, but I think it's is a step forward, to try to overcome the price of success, which is the fact that we are going to need a lot of patients and a lot of time to see the clinical trials in the future mature and to be able to apply, the potentially best treatment options to the patients with myeloma. So the FDA has approved this. So MRD negativity in patients in CR at 9 or 12 months from randomization as an conditional early endpoint for treatment approval in patients with myeloma. This is not the situation yet in the European Union. So I have to acknowledge I'm not involved in the process of approving this in the European Union. I guess, so no, of course, in the European Union, MRD is recognized as a very strong prognostic biomarker in patients with myeloma, but it's not yet accepted as a surrogate endpoint as it's already in the States. And basically, I think, I don't know, I think the conditions are there. So I mean, we could think about well, the methodologies are not fully standardized. I would say that next generation sequencing it is, and next generation flow it's also standardized. Maybe maybe they want like more data regarding maybe the level of sensitivity. Maybe they want more data regarding it's going to be, so the time point is going to be just, reaching MRD negativity, or it's going to be sustained MRD negativity, or should we include in this definition also imaging methodologies or other factors such as toxicity, for example, quality of life of the patients? I don't know. I think so. Probably they are being more cautious. They are, waiting a little bit for the evolution of the decision of the FDA. But I would say that the landscape is completely favorable, to approve, the same, so MRD negativity, so with the same idea as in the FDA, probably trying to, to address a little bit better all these questions, and to accept it hopefully in the next few years. So we have talked about so the application of MRD in clinical trials, and you probably asked me, what about the application of MRD in routine practice? So it has been applied. We have data about the clinical value, again, of reaching MRD negativity in patients treated in real life. You have the results of one study this is from the Czech group, published a few years ago, patients post-transplant. On day 100 post-transplant, you can see, the prognostic value of reaching MRD negativity. It's completely clear. So, and the next question would be, so are you taking, or can you take clinical decisions based on the results of the MRD that you are obtaining in the clinic? It's true that we have been asking ourselves this question for many years now, I would say, and we're still waiting for the results of more trials that that are gonna be out in the next few years to to have more support to take clinical decisions based on the results of the MRD. But I think I can comment with you like 3 examples that could be illustrative, I would say. So the first one, could we use MRD, for example, to deepen the results? So to deepen the response and improve the results of the patients. So this is the Auriga trial. We do not, probably you have heard about it. Just so patients that did not respond correctly after transplant. So that did not achieve MRD negativity at that time point. So they were randomized to receive Len-Dex or, Len or Dara-Len only. Those that received Dara and Len reached a higher percentage of MRD negativity, intensifying the treatment, and this group of patients did better. So MRD was used, as a marker, to treat the patient post-transplant, and those that reach MRD negativity, actually did better did have a better outcome in terms of progression-free survival. Here, the results of the Auriga trial. So can we de-escalate the treatment? This is probably the situation that has been commented in more detail. So patients on treatment, MRD negativity, sustained MRD negativity for 3 years. Can we de-escalate the treatment? So there are, so the example that you all know, so the Perseus trial. So you know that in those patients that were after 2 years of maintenance were in sustained MRD negativity, in those patients, daratumumab could be stopped. So we are using MRD negativity in this trial and in others. So in those patients with maintained MRD negativity to reduce the intensity of the treatment, and this, once approved, is going to be applied in our clinical practice from now on. And the third condition that I think we need more data in this regard. So if one patient is MRD negative, and then in the follow-up the patient becomes MRD positive because he or she has a bone marrow aspiration once a year, and being negative in the peripheral blood, the marrow becomes positive. Should we treat this? So in my view, this is, preliminary. We only have preliminary results about the value of this, and I think we should be cautious. In this situation, we have to wait for more results. We have to wait for the meaning of this in the context of the new treatments that we are giving the patients. So in this situation, I think we have to be careful about, taking clinical decisions as of today. In this regard, we have also clinical trials. The Remnant trial that is exactly testing this. So the clinical value of treating the patients when they progress according to the International Myeloma Working Group criteria or when they become MRD positive. So the assessment of MRD in the marrow has a lot of advantages, but it has disadvantages as well. So we have commented that we only assess a few milliliters of the blood. And the second disadvantage is that we obviously need a bone marrow aspiration to assess the disease in the patient, and this cannot be done every month because you all know that it's a painful, inconvenient procedure that cannot be done with the frequency that we need to monitor the treatment. So the future, I think, is the assessment of MRD. So considering MRD, the presence of disease beyond the conventional response criteria of the International Myeloma Working Group in peripheral blood. So peripheral blood is currently being tested with different methodologies, so very sensitive methodologies to try to identify the presence of disease in peripheral blood, because in peripheral blood there is always less disease as compared to the marrow. So 3 examples. In summary, what I would like to say about the assessment of MRD in peripheral blood is that, so as of today, peripheral blood is less sensitive as compared to the marrow. It's less sensitive as if you compare next generation flow, next generation sequencing with mass spectrometry, and it's less sensitive if you compare next generation flow, next generation sequencing in the marrow with the presence of circulating tumor plasma cells in peripheral blood. It's always less sensitive, but it's more sensitive as compared of what we have today, as compared to immune fixation in serum. So they all have prognostic value, but again, the marrow, the assessment of the marrow is more sensitive as compared to the approaches in peripheral blood. So we are going ahead. We are not yet comparable to the marrow. So the first one, mass spectrometry. Mass spectrometry is able to identify the molecular mass, the specific molecular mass of the monoclonal protein of the patients. This is a specific of each patient, of each tumor clone. Mass spectrometry is able to identify it and to follow it. The results, we have tested it in the context of this trial. There are many other examples, and the results in terms of sensitivity, I've just commented them with you. So mass spectrometry is more sensitive as compared to immune fixation, less sensitive as compared to the analysis of the bone marrow. Mass spectrometry has clinical value, but less clinical value as compared to the analysis of MRD in the marrow of the patients. Better as compared to immune fixation, less as compared to the marrow. The identification of circulating tumor plasma cells in peripheral blood in patients in complete response, same thing. We are testing highly sensitive approaches such as blood flow. They have clinical value in patients in complete response, but again, the marrow has an additional clinical value due to its higher sensitivity. And in conclusion, so why should we assess MRD? Because it's the strongest prognostic factor in myeloma. With which technique? So you can use the one that you have more available, next generation sequencing, next generation flow, and don't forget about the imaging methodologies. To whom? To everybody with myeloma. It's prognostically useful and clinically useful in every patient with myeloma. When in CR, and sequentially to determine that status of sustained MRD negativity that define a good, so a subgroup of patients with an excellent outcome. In clinical trials, knowing the approval of the FDA is going to be included in all the clinical trials, and in routine practice, we can use it today to guide the treatment. You have the example of the Perseus trial and others during maintenance. And then the future, in my opinion, is the combination of the assessment of MRD in the marrow of the patients with the assessment of what can be also MRD in the peripheral blood of the patients with myeloma. And these are my acknowledgements, and thank you very much for your attention.